there's no good reason, for example, why the overall health status of Americans has dropped for the 14th year in a row when we are the wealthiest country on earth. It says that we don't have our priorities right. We're not looking out for the welfare of our people. That makes this a less desirable place to live than we've always imagined it should be.
I am beyond thrilled to welcome Brian Klepper, an incredible healthcare activist and someone I deeply admire, to the show today. Brian has dedicated his career to promoting better healthcare at lower, transparent prices, all while fearlessly calling out the unethical practices of major players in our traditional healthcare system, like insurance companies and hospital systems, that harm our communities and economy. Brian introduced me to one of the most mind-blowing and little-known aspects of healthcare policy, the AMA's RUC, or Relative Value Scale Update Committee. This committee, sanctioned by the AMA, determines how physicians are reimbursed by Medicare, which heavily influences how commercial insurers set their rates. The RUC operates in a way that pits physician specialties against each other because the Medicare payment pie is fixed. If one specialty gets a bigger slice, another specialty must take a smaller one. This creates a system of division among physicians, ultimately empowering those who profit off of our work and the care of our patients. What's even more concerning is the representation on the RUC. Higher paid specialties are overrepresented, while lower paid prevention-focused specialties like primary care and endocrinology are underrepresented, or in the case of endocrinology, not represented at all. This disparity perpetuates a vicious cycle. Lower reimbursement for critical specialties leads to fewer physicians entering those fields. Worsening shortages in areas like endocrinology, even as diseases like diabetes, one of the most prevalent and costly chronic conditions, continue to rise. This system disincentivizes preventative care and high-value service while rewarding reactive, procedure-heavy care in hospital settings. The result is a system that doesn't prioritize patients' best interests, and it's all happening under the radar. Shockingly, 99.9% of physicians don't even know the RUC exists, let alone how it affects their work or pits them against their colleagues. When they do find out, it feels inherently wrong because it is. In this episode, Brian and I dive into the RUC and so much more. We discuss the importance of outcomes, data analysis, and accountability in improving healthcare, and how we can address systemic issues that put profits ahead of patients. Brian's perspective and expertise are invaluable, and I am so grateful to call him a friend and have him here today. I hope you enjoy this enlightening conversation as much as I did. Be sure to check out the show notes for all the links and resources mentioned in the episode. Let's get started. Today we have Brian Klepper on with us, and I am so excited to have Brian here today. I have learned so much from Brian throughout the course of the past several years in this new space that I have been exploring and learning about and working in terms of direct care, in terms of value-based care, in terms of trying to solve the very important problems that we're trying to solve for diabetes and endocrinology patients. And Brian's insight into this space has taught me so much. So Brian, welcome to the show. And I know you had something that you wanted to open with, so please just go ahead and get started.
Well, I'm delighted to be here, especially with you. So here's what I was thinking this week, or one of the things I was thinking about this week. The International Foundation of Employee Benefit Plans, which is a union healthcare organization, issued a report this week that said that none of the cost containment approaches that are in the marketplace, there's no evidence that they can find that they work. And my response to that, and I'll put some context behind that. My response to that is I think they're asking the wrong questions. And I think they're focusing on general approaches that are applied with huge variation across different care delivery organizations or care management organizations, and that you shouldn't be looking at the category of what they're doing. You should be looking at what their results are. And if somebody is a practitioner of diabetes care, for example, you can't just say, oh, well, they do coaching. You have to say, this organization has a particular approach that it uses, and they have taken it to a high level, and that organization needs to be scaled. There is no evidence that category of approach needs to be scaled. Those are two entirely different processes. So for those of your watchers who don't know me, which is probably almost everybody, for the last 10 years, I have focused on identifying and vetting very high performing healthcare organizations. And the definition of that is organizations that consistently deliver measurably better health outcomes and or much lower costs than conventional care, and particularly in high value niches where the money is. So I'm not particularly interested in wellness, for example, because there's just not a lot of data that shows that it works. Or maybe another way to say it is at all. There's just nothing showing that it works. But I'm very interested in areas where the money is. I'm interested in management of cardiometabolic chronic disease. I'm interested in management of musculoskeletal care and of complex disease generally. So, for example, complex disease generally is, think of that as the cancers, the degenerative, the neurodegenerative diseases like Alzheimer's and ALS and Parkinson's, which I have, and the rare diseases. Those diseases affect 6 to 10% of the U.S. population, and they eat up more than a third of all the money. And so they are, to put it in crude terms, they're a high value target. And when you dig into areas like this, and the same thing goes for diabetes, actually, there's very little that's done that is standard of care. And it's reflected in the poor control rates of these diseases. So for those in your audience who aren't familiar with that term, what I'm referring to is the percentage of patients who have a particular chronic disease where if you test them, their numbers are within acceptable limits or they're not. And if they're not within those, then they're out of control. So American chronic disease control rates are terrible. They're embarrassingly terrible. So if you go to the CDC and you say, what percentage of people with hypertension have it under control, the number is currently 44%. And so 56% of those people are out of control, which means that they're going to go on to have other more terrible things. They're going to suffer a lot more, and they're going to cost a lot more and die younger. And we sort of don't do anything about that. And if you go to and you talk to the docs about it, they'll say, and you say, well, why do you suck so badly at this? and they'll tell you, well, the patients don't do what we tell them, which turns out to not be true. It turns out that to accurately prescribe for these patients, you have to the clinician has to accurately juggle 50 different variables in their heads at the same time, and that is pretty much beyond the limits of human capability. The more you get into the cardiometabolic diseases, the more complex ones, the worse the control levels get. So if you look at diabetes, 10% of the patients are under control. If you look at heart failure, 1.5% of the patients are under control. And so until recently, there have been no real concerted efforts to use evidence to create standardized practice patterns that can defeat this most serious of all healthcare problems at a societal level. And I think that where you are headed is exactly in the right place as a result. And that is not a small thing. That is a very, very big thing.
Well, thank you. There's so much to unpack there. So I think first, it's a travesty, right? I mean, 10% of people living with diabetes are under well control, and probably those people are getting some sort of care, in air quotes, that, it really begs the question, is that care? Brian, why do you think it is that we have such poor control of these chronic cardiometabolic diseases?
For one thing, we don't track them. We don't track control levels by doctor. They do in a few parts of the country, but the American healthcare system is so crazy. And as a quick aside, I'll tell you that I have spent the entire last week writing about with other people the killing of the UHC CEO, which is a terrible tragedy. But I think the important thing about that event is that on social media particularly, which covers a huge swath of American opinion, this was not a normal event. And there have been an overwhelming number of people of all political persuasions, of all demographics, who have stood up and said, we have no sympathy for this. Organizations like United have preyed on the American people, and they have done it unethically and more often than not illegally. Nobody takes them apart as a result, and it's all about the money. My 45-year-old attorney son gave me an earful about that last night, which was actually enlightening. But the healthcare system's structure has not incentivized quality of care, and it has not incentivized efficiency of care either. So but they have exercised control, which allows them to skim off the top and to make immense amounts of money. So because we live in a society which has decided that the way we write laws is to give your senator and congressman more money than other people give him so that he'll do your thing in your favor, we have a system that is utterly dysfunctional. And it's absolutely not in the patient's interests, and it's absolutely not in the interests of anyone but the guy who's making money on it, which is the cynical answer. But it also threatens democracy. It also threatens professionalism. And so the physicians today have a completely different experience and mindset than the physicians did 50 years ago. In my day-to-day work, I'm now, among other things, I am doing performance reviews on worksite primary care clinics and trying to see whether they actually deliver value to the employers. And more often than not, the data says they don't. And that's not because they can't. It's because they don't have an incentive to really be accountable and take the steps necessary to be effective. So they coast because nobody's looking at the data. And patients are the victims in that.
Yeah.
The reason I became so interested in you so quickly was because you are antithetical to that. You are all about the patient, and you're all about the science, which is the only way to really be effective.
And the data. I think that it is, yes. What you mentioned about the data is I have always tracked my data from the second I graduated from fellowship, mostly out of curiosity. I was an employed physician when I first came out, and I wanted to see if some of these newer therapies were actually working for my patients. And that's kind of where this obsession with data came from. But I want to ask you a question about what you said. You said the system is only working for the guy who is making money off of it. Who is that guy?
Well, as you've seen, they're typically nameless and faceless, and they're hiding. And now, rightly so. I think that there was an article in the Wall Street Journal yesterday that said Brian Thompson was just a guy doing a job, but he wasn't. 6 or 7 years ago, I wrote a piece about a United group, a United Health Group subsidiary that provided behavioral health benefits, and so employers paid the premiums, they bought the benefit design, and then this organization systematically denied all the claims, and pocketed the money. And they got sued, and it dragged on and on and on and on. And in the ruling, the judge wrote that United's representatives had been evasive during the entire process, and even deceitful, he said. When you are the biggest insurance company in America, and one of your subsidiary organizations is truly and fundamentally dishonest, and there's a documented record of that, and they tolerate that and they defend it, that says the entire enterprise is a criminal enterprise. And that's where we are with United. So this guy who everybody refers to as a family man, and he had young kids and so on, and he was a great guy and all that. He's like Michael Corleone. And the problem that has emerged is that companies like this are preying on the American people, and they know about it. And this overwhelming celebration and skepticism and mocking discussions about him is a sign that people aren't just responding off the cuff. They've had years to experience this and be fearful and vulnerable to it, and they really are expressing how much they loathe these organizations. I think it's a big moment in healthcare, and I think it's a big moment for all the different problems that we have, including how we treat patients poorer than we could.
Absolutely. And I love that you brought up this idea that clinicians say, oh, the patients don't listen, because in my experience, certainly there are the rare few that perhaps won't listen, but those patients probably, in my experience, also have very complex socioeconomic issues or other issues going on that disable them from following their prescribed plan or working as a partner with you in their care. For the most part, patients do listen. And I know this because of tracking data. And I know this because we worked with a population of poorly controlled people living with diabetes, but were poorly controlled, so with A1Cs greater than 9. And we intervened with them. And that intervention was introducing me as an endocrinologist. Nothing else was added to them. They weren't given any other support outside of an endocrinologist who gave them time and support. And I watched their A1Cs come down, and more importantly, they were engaged. They were listening. They were hearing me. They were partnering with me in a plan. They were learning about their lifestyle, and they were engaging in that. And these patients dropped their A1C from above 9 by more than 3%. So many of these patients went from poorly controlled to well-controlled, dropped their risk of complications tremendously, and reduced their risk of potential costs to their health plan or the healthcare system tremendously. And that was just changing one thing. And so I think we have this idea, or maybe it's shirking the responsibility because we feel like we're not in control or we're not tracking our own data. I think data is the most empowering thing for a physician. And it's an educational tool, right? I started it because there was these weight loss medications that came out close to when I graduated from fellowship called, there was one called Qsymia, and there was a guideline with it in it, and it was expensive, and I wanted to see, does this really actually work for my patients? And my personal data kind of showed that it didn't. It wasn't really worth their time and money. And I think that data actually enabled me to reduce their out-of-pocket spend, because I was like, I don't know if you guys really should try this. You can if you really want to, but in my experience with the last, 50 patients that I tried it in, didn't really work in my personal experience. I think that's incredibly empowering. And I think patients are coming to us, yes, for us to know the evidence that exists and, for our knowledge and expertise and training, but they're there for our opinion. And we can only have an opinion with data. And some of that comes from experience, but also I think it really strengthens our argument for our patients when we have facts.
I used to own a primary care, a worksite primary care company. And one of the things I learned was that primary care is not about being a gatekeeper or anything like that. That's silly. No competent primary care physician that I know thinks like that. They are there to be patient advocates and guides and to manage complexity and also to manage risk, clinical risk and financial risk, wherever it occurs in the continuum. So the primary care clinician sits at the center of power in healthcare, which is also happens to be at the front door of the healthcare system, and should be using data to identify who needs to be in the queue right away, and is the core source of trust in the entire healthcare transaction. The programs that I'm working on, we think that we'll be able to go to employers and say, if you work with us through a design of advanced primary care clinics, which are focused on traditional primary care functions, prevention, modest acute care, and management of chronic disease. If we can marry those to specialist organizations that are truly high performing and that are focused on very high value niches, chronic disease, complex disease, drug spend, maternity, surgery, all of those costly areas, that we can guarantee a 25% reduction in total healthcare spend within 2 years, with better health outcomes, along the way. We think that that's already achievable, and the thing that I want your listeners to get is that you represent the leading edge of the new wave that is capable of participating in and leading that effort, because you've already demonstrated it.
Oh, well, thank you. I think, that is how primary care should be. And I think it's important to address that primary care doctors are well-trained, board-certified physicians. And because of the way the healthcare system has gone, they're almost treated as though they're secretaries or an avenue to a specialist that you really want to see. And that's only true if they have 5 minutes to spend with you and all they can do is refer or write a prescription and no support in between. We're going to talk about this much more, but the way reimbursement has dwindled for specialties like primary care and endocrinology. I don't know if you saw the recent Medscape physician compensation report, but we actually fell below pediatrics as the lowest paid specialty in endocrinology. But the way the compensation structure has gone to prioritize reactive specialties that are more in the hospital, performing surgeries, and kind of dissuaded medical students from going into primary care or other fields that actually focus on prevention and are cost saving in that way, has changed the way that people perceive primary care. And my hope is that as we show with real numbers how much cost savings primary care doctors can do when they're given an environment where they can perform at their highest level, my hope is that perception will change. But do you think we're anywhere close to that?
Well, the problem that you're describing, the culprit in that is there has been an unholy relationship between CMS and HCFA before CMS, which is the previous name, and a secretive committee of the AMA called the RBRVS Update Committee. And in between 2010 and 2013, I threw everything I personally had at exposing the ruck, which is the committee is made up of, I want to say 31 physicians, of whom 5 are primary care and the rest are all specialists. And they have a sole source contract with CMS to define the value in RVUs of every medical procedure. And it is hidden. The processes are all hidden. There's no transparency. It's run by horse trading between different specialties, and it's designed to do everything possible to make to go around primary care and get the patient directly to the specialists where much more lucrative diagnostics and procedures can be done. The GAO ultimately took the work that I did, and they did an analysis, and they went, this guy's right. But they didn't do anything because there's so much political power behind it. So that's another really big problem, and it's a problem for endocrinology particularly.
What is the GAO?
The General Accounting Office.
Okay.
The U.S. General Accounting Office, that does investigations into different things in the country. But since diabetes is, I think, our most costly single disease, and it's exponentially getting worse because of the diets that we're on. This stuff matters. Every day of my life, I get calls. Every working day of my life, I get calls from startup companies or somewhat established companies that want to tell me how wonderful they are.
Mm-hmm.
And they recite all the things that they can do, and then I ask them a set of questions that are designed to have them tell me the basics of what they're about. And the questions they're really quite simple, and it's taken me a while to develop them. Not the brightest bulb here. So I asked them, can they show me longitudinal data, long-term data that demonstrates that they consistently get better health outcomes and or lower costs than conventional approaches? Most of them don't have the data. They can't show that. Are they willing to go at risk? No, they're not willing to do that. So they're not willing to guarantee their results. Are they? Do they have 7 testimonials that they can refer me to talk to clients that they've got that demonstrate that'll back them up and say that they deliver? Are they sticky, or do they get more participation over time as a result of their work, and so on and so forth? There are very few organizations that do this well, because diabetes is such a big target, and there's so much money that flows through it. There are lots and lots of companies that that are in this space and that claim to manage it very well. The most notable or rather notorious of them was Livongo, which basically used its money for marketing and couldn't prove that they did anything that was worthwhile. They ultimately sold to Teladoc for $18 billion, and then Teladoc took a really big hickey on that. But they were just a worthless play. They got tremendous buy-in from the fortune companies until they didn't. And I see companies like this every day. And so the reason that I was so interested in having a public talk with you is because you're in a very interesting position. You have developed a genuinely better way. It's not like rocket science or anything. But it's sensible, and you get consistently better health outcomes at lower costs than almost all of your competitors. I can think of maybe one that is in the same league. Employers in this country and brokers in the country have been reluctant to move to work with point solutions, and they would consider you a point solution, because it requires somebody at the employer in HR to manage the contract outside of the health plan, and that's sort of onerous. And people at the employer, they don't know anything about this, and so we end up with employers who have a lot of point solutions that they don't understand, and they don't perform, and they don't know what to do about it. And that means that it's more and more difficult for the point solution company that's even those that are doing fabulous jobs to get into the marketplace so that they can generalize what they do and succeed. So what I realized was that what we need to do is get true high-performing point solutions that from all different niches, and get them to collaborate to functionally create the basics of a new high-performing health plan that takes risk where the vendors each take risk. It's integrated with advanced primary care, and it pushes what it does out into the marketplace, because the major health plans are not going to buy into it. They want healthcare to cost more, because if it costs more, they make more money. So the task ahead of us is for organizations like yours to get enough footing to work with other organizations that are your true colleagues, but in different spaces than you, and to offer a range of services to populations that you wouldn't otherwise have access to.
You're absolutely right. I think that is the whole foot in the door thing is the hardest part, getting people to, you have the outcomes, but getting people to take it seriously, and figuring out how it fits into their greater plan is the challenge. We've had some great employers that have taken, I guess, taken a risk on us, and I think that we have performed very well and had, we track not only hard clinical outcomes but also patient satisfaction scores, and I think we've done well. But I think that's a great idea as far as kind of collaborating, coming together and creating a multi-specialty, outcomes-driven, truly high-value product that can be more palatable and less onerous as far as admin for a client. It's just finding those solutions. What I've learned is physician-run companies are great, but they're very few and far between. And physicians, it's very difficult to get them to wrap their head around tracking their own data. I've been pushing my colleagues to do it for 6 years now, and literally zero have done it, except one endocrinologist who I hired, who's on my team, and she did it for me. And so not even on a large scale, but it's tedious to do it correctly. And perhaps they don't have buy-in by their hospital systems if they are working in a large EMR, but getting physicians to track their outcomes, I truly believe is almost our ticket to freedom from some of these big corporations. Because if we can say we can do it better without you, then, and for far less cost to the patient, then we have something there. But getting people on board to do that has proven challenging for me, for sure.
Tell me why it's difficult to get that done. Wouldn't it be in the interest of the provider organization to simply make that data available to every clinician?
I have a theory on it that maybe isn't the most positive, but I don't think that systems want their physicians to know how good they're doing.
Right.
Because then they'll leave.
That's almost certainly true, yeah.
And so I think that they make I've had my own company for years, and I've sort of tracked data. I've anonymized data on my own and tracked it separately on like Excel. You know this, I'm very high tech, right? On Excel by myself. I haven't always gone through the system to track it, mostly out of curiosity, and now just for the sake of our business. But so it's essentially like having an Excel spreadsheet on one monitor and your patients on the other monitor, and putting it in as you go. That's how you track your own data. And that's another step on top of seeing the patient, doing their orders, all that's in a short window, too short for even doing those tasks. So going above doing something else on it, I just think is unpalatable. And also, I don't think many physicians, I think physicians are so on the hamster wheel. They're busy taking care of patients that it's difficult to step back and see the big picture. I remember I left my practice in January of 2019 when I was employed, and I told my husband 2 weeks later that I felt like my brain worked again. And I had no idea that my brain wasn't working. And the craziest things happened because I wanted to start my own practice, but we were a year and a half out of fellowship. So we had a lot of medical school debt we were paying off, and we had 2 very, very young children. And I came up with a plan of how we were going to tackle some of these things and how I was going to tackle starting my own business, because I was free from that. And we saved so much money that year without me practicing full time like I had been, that my husband and I decided there's no reason for me to ever go back to practice like that, because we saved too much money with me not practicing for it to be worth my while to practice in that type of setting. It was crazy. So I wonder, what you were saying kind of led me to think, since our big BUCA insurers, Blue Cross, United, Cigna, Aetna is what I mean when I say BUCA, and hospital systems make money off of illness, essentially. They aren't incentivized to have these tremendously good outcomes to prevent hospitalizations. Do you think that we can make massive change within traditional insurance?
No, we have to co-opt them. And the only way to do that, they captured the regulatory process with lobbying. And so all the laws and rules get written to their specs because they have the biggest bribes, and our system of government is receptive to that. So the only way to work is in the market, and it boils down to giving people a better mousetrap and making them an offer they can't refuse. I mean, the thing that will work to break employers away from the brokers who are setting them up with health plans that are paying them huge commissions under the table is to offer something that is so much better for so much less money that if the benefits manager blows it off and the CFO finds out about it, the benefits manager will lose her job. But other than that, they've got us hogtied. Which was one of my son's issues, by the way. Says everybody I know knows that they're being forced to play a game with the health plans. There's no alternative to that, and they we lose every time they're in a control situation, and so there's this pent up fury, and it's corrosive. It's corrosive to the country. The only opportunity is to find models where everyone comes together. Everyone comes together so that you have enough momentum to succeed in the marketplace and be disruptive that way.
I think so, but I think that people in general are so brainwashed, I think, into thinking that their insurance card is a card that they can give out for their health. It's like a credit card that they give out for their health care and someone else pays the bill. And we have our employer-based company, and we also have a direct care clinic. And there are some people who understand. There are people who have probably had experience with the healthcare system, but perhaps it's cognitive dissonance, but trying to get people to understand that a clear, upfront, transparent price is better than here's my insurance card, bill you later, good luck, is actually better and more straightforward, is a confusing challenge. Because if you were talking about groceries, right, nobody would be like, okay, yeah, let's go put whatever I want in my basket and then take it home, eat it, and then they'll send me a bill later. Nobody would do that, because that sounds like the grocery store would take advantage of you, right? But that is exactly where we're at with healthcare, and people are so comfortable with it.
Well, on the other hand, they may be comfortable. I think that the events of the last week with this shooting has revealed that there are a lot of people who do not think that those people are going to take care of all of us. And when I was running the primary care company, the worksite primary care company, I learned we had a model where if you got your care from the clinic, you paid nothing to go to the clinic, and your labs and your drugs and your images were free to you. And if you needed to get a referral, for a normal population right now, 25 to 35% of the enrollees see a specialist during the course of a year. We were at 11%, with better health outcomes because we allowed the specialists to practice what they had been trained to do. And so we had very low specialty referral rates, which dropped the cost dramatically, and the patients got the drugs put into their hands. And if they got referred, they went to the referral physician that we recommended, they paid no copay. The incentives just need to be aligned, and they need to be enforced. But you've got to, if you're going to take that approach, you'd better have integrity about it.
I think this steerage is helpful for cost savings, but the integrity piece sometimes gets lost in that it leads to, like with Medicare Advantage, like less care, delayed care, denied care, as opposed to truly referring to a high value cost saving approach. All this makes me, so there's no endocrinologist on the RUC. I don't know when the last time there was an endocrinologist on it. And it makes me wonder.
I didn't realize that.
Yeah, I looked. I have everybody's name, and there's 32 members. No endocrinologist, and it makes me wonder. This conversation makes me wonder if it's worth our time to get on that committee, because I don't.
Probably not.
Yeah, I don't know if that sort of environment where we're a preventative specialty, at least we should be, and inherently that should mean we're cost saving. But if cost saving is not the goal of anybody, then that's not going to be an argument that serves us on that. And I wonder, I'm sure you've seen the trends with psychiatry going out of network. I wonder if, and now it's almost a norm, people can accept that if they're going to see a psychiatrist in a reasonable way, they're going to pay out of pocket. I wonder if that is the trend that endocrinology should follow.
That's a conversation for another person that I know that I can introduce you to, a guy named David Belinsky. David runs a company called Wire Health that is dedicated to management of high acuity mental health patients. Mm-hmm. So here we're talking about the 0.3% of the population that consumes 12 to 14% of all the money, and their patients are potential suicides, anorexics, sharp object swallowers, people who are very severe pain, and they have learned how to manage those kinds of patients well to make them functional in society and to make them cost a lot less. And so the question is, you're asking a legitimate question, which is what role should our profession play in the overall scheme? And is it a vibrant profession? Does it represent current science properly? I would argue that it may be that cardiology as a profession maybe doesn't so well. That we've come a long way to realize that these are intricate systems that are not organ based. They have all kinds of dimensions, and there needs to be broader training to do it properly. Endocrinology is so important simply because it's such a big part of overall disease, and it also is the keys to the kingdom, as Dr. Besterman has done a pretty good job showing. It's the keys to the kingdom on understanding how chronic disease works and how aging works and how they're all part of the same mechanisms. Sort of one of the great things about Dr. Besterman is that he's focused on sort of a unified field theory of chronic disease management at the molecular level. I worry that this conversation has been all over the map. Maybe some people have thought of it as a short attention span theater discussion, but when you're sitting in the center of the cyclone, there are all kinds of different things that you have to think about simultaneously. And especially when you're trying to build something that is meaningful along the way, which is what you're trying to do. And I admire it so.
Oh, well, thank you. And I admire your work so much too. I think endocrinology, I thought a lot about the ruck when I was preparing for this, but throughout it may not be getting power there that seems to be the solution. Endocrinology feels like sometimes the redheaded stepchild of specialties and primary care, because specialty care, many people will say, drives up the cost of care, whereas and the idea that people have is that primary care is cost savings, which I agree with. But endocrinology is a specialty. We train as long as the orthopedic surgeons and cardiologists. But it is also preventative, and we don't seem to fit in either one of those buckets, because when we consider specialty care that's high cost, that's not really us. And when we think about reimbursement too, I think a lot of times people think about when physicians are fighting for better reimbursement, it's kind of seen, at least by the public, as physicians want to make more money. And I think we need to walk away from that narrative, because ultimately, you know this, I have certainly sacrificed my income to provide better care in a different model. But I think reimbursement enables care, right? It enables us to provide for our patient. And if the reimbursement is low, we can't do as much for our patient because we don't have the support staff and the necessary tools to do that. So changing that narrative, I think is important. And it's important for doctors to see it that way too, so that we can communicate that well with patients. But in your opinion, what do you think we could do to lift endocrinology up as a specialty? As you know, there's a huge shortage. There's only about 7,000 endocrinologists in the country, with about 38 million people living with diabetes, not to mention the rest of the conditions we treat, as well as the fact that endocrinologists are retiring faster than we are minting new fellows, and interest in the subspecialty is going down due to the fact that the training is long and the reimbursement is low. What do you think we can do to uplift the specialty?
That's a very good question, and it's a tough one. I mean, first of all, I think the entire methodology for how physicians are paid is crazy. And it's been very destructive. A few years ago, I was asked to give the keynote at the North American Spine Surgeons Conference. And that's a pretty confident group. And I got up and I said to them, I took a deep breath when I did this. And I said, it's an open secret that half or more of all the surgeries you guys do are inappropriate or unnecessary. And guys like me can see it in the data, and there's going to be hell to pay. And you need to stop. But they do it because they make so much money at it. I think that what endocrinologists need to do is they need to be able to demonstrate the value of what they do and how that plays out and how what they do translates into better lives for people. There needs to be an appreciation of what you're doing, and there needs to be a strong effort within endocrinology for everybody to practice in the way that the very best clinicians in endocrinology do, with metrics that demonstrate that patients are better or not than before. It needs to be a very open and transparent celebration of what you do and why you do it and what happens as a result, because patients have no idea. I mean, take this to the extreme. How many people do you think know what a rheumatologist does?
Yeah, not until they go see one or they have a autoimmune disease that needs a rheumatologist. Right. I think we have a couple things that give us a disservice. We're a very cerebral specialty. We don't procedurize anything. People can understand surgery. This person is trained to do my knee replacement. But when it's cerebral, people can't really see the amount of thought. But like I mentioned, our training is as long as an orthopedic surgeon's. So there is a lot going on, and many fields outside of medicine train for a long time, and we appreciate that expertise. But in healthcare, it's different. Our specialty is called endocrinology, which is intrinsically difficult to understand. People are like, what is that? I think those two things make it really difficult for people to understand what it is that we do and what we can do better than, somebody who doesn't have our training.
I'm pretty sensitive to it. I've got two of my daughters are type 1, and it dominates your life.
Yeah. It's with them every second of every minute of every day. And I also think that since our reimbursement structure is similar to primary care, but we are tasked with the most complex patients, you can't see the same volume. And so what has happened is this adversarial relationship with people living with diabetes or other hormonal diseases who aren't getting the adequate support that they need from their endocrinologist because their visits are so short and far between. It's actually almost impossible to even get into an endocrinology clinic as a newly diagnosed person with diabetes, which there's a lot of systematic issues that have led to that, but that's not what the patient sees and experiences. They say, this doctor doesn't care enough about me to spend time with me or get me into their clinic.
Arti, what you've been doing, what you've been working on what you're working on now for a few years now, and you're in a very dynamic organization and in a very dynamic marketplace. What is it that you are thrilled about, and what is it that you fear at this point?
I'm thrilled about the fact that we can make a difference in the lives of other human beings. Every single patient review or remark about what we're doing that is positive, and there are many, it still lights up my day. And that's the point. It gives me joy, it gives me purpose, and it gives me the will to keep forging forward even on the hard days. It's the patients that are doing better and living better and are happier. What am I most scared about? I don't know. I think maybe I'm most scared that I one day will lose the fire. I'm nowhere close to that, but it's a very challenging space. It's very hard to get taken seriously. Not only am I in a competitive space, I'm also a woman of color, and there's a lot going against me, and I know that, and I see that. But I think that's my biggest fear of losing the desire to continue to grow a movement for better care.
I suspect that's not what you just said is not going to be the problem, but I mean, it could be, but you seem pretty committed to dealing with this issue, and you'll have your ups and downs, but in your heart, you're devoted. And, but I think you're right about the difficulty that you'll have in keeping it up. I think there are lots and lots of opportunities for what you do. Some of it has to do with becoming involved with the structure that exists in the country, with organizations like the National Academy of Medicine or organizations like that. But the problem is only going to continue to get worse and worse. And it's very frightening. And there just aren't a lot of people. There aren't a lot of people who are doing what you're doing. And when I look at the diabetes management space, everybody's program, except for a few, are focused on coaching. But I think it's got to be much earlier than that. And it's a much bigger reliance on a physician who's going to prescribe accurately, and he's going to be there with you, and all of that.
I agree with you. I know exactly why coaching is the place where people are focusing. It's because that is you have the highest margins there. Physicians just don't have the same margins, and endocrinologists are very difficult to find. You just can't hire somebody. It's really difficult. I think the only reason that I've been able to hire two of the best endocrinologists in the game, as far as clinical acumen and as well as patient satisfaction and just compassionate, wonderful care that people want to have, is because the movement to do something different. And of course they need to make a living, but it's not financially motivated for me or for them. And we are truly on the same team with shared goals. But otherwise, it takes big hospital systems months to years to hire a new endocrinologist when they need one, and they all need one. So yeah, it is a challenge to do a physician-focused diabetes program with endocrinologists kind of leading the patient management.
It sounds like an opportunity to, one afternoon you should draw a flag and have that executed, and then recruit endocrinologists from around the country who want to practice like you're practicing, and get strength that way, and then have more leverage to be able to do the kinds of things that you want to do.
Yeah, I think that's one of the motivations of this podcast, is to tell other endocrinologists, over 70% of endocrinology fellows are women. So it's a group that I can speak to, that there is a different way, that we don't have to shirk our moral obligation to our patients to survive and practice endocrinology. We can do it in a way that serves us in every dimension, including our ethics, our families, and our intellectual curiosity, while also serving our patients.
As sort of a closing comment, let's talk about some more of that offline.
Yeah.
How you might gain leverage and strength in what you're doing, and because I think that's what needs to happen. Life and influence are about sphere, or life and success in what you're doing have to do with sphere of influence, and you've got the makings of that. So it's really very admirable and a pleasure to see.
Thank you. And honestly, that checklist that you were talking about with your high-performing companies and individuals, I wrote them down the first time you ever the first time you ever told them to me, and I have them on I screenshotted my list, and I refer to it to say, are we meeting these benchmarks? And that spurred me to work with the Validation Institute to get our data validated, because I wanted to, it was just such a great list, and it was a clear sort of checklist of things that I could do to ensure that we're delivering a promise to our patients at a level that other people can understand and help us help more people. So you have been instrumental in our business, whether you knew it or not. But as we close, I wanted to know, do you have any closing remarks or anything that you didn't get a chance to say that you would like to add?
I don't think I hide the fact that I don't think very kindly of major healthcare organizations, and I don't think that I think that we've lost our way in this country in healthcare and a lot of other things, where it comes to ethics and other core values. And I think that the value movement that I'm part of and that you're part of is an effort to bring that back to a homeostasis that we can all be comfortable with. There's no good reason, for example, why the overall health status of Americans has dropped for the 14th year in a row, when we are the wealthiest country on earth. And it says that we don't have our priorities right. We're not looking out for the welfare of our people, and that makes this a less desirable place to live than we've always imagined it It should be. And so I'm very concerned about that, and I hope that your listeners are very concerned about that.
Same.
But I think that you're one of the answers.
Thank you.
So,
I agree. Aligning incentives between care providers and patients is truly the start of something beautiful. And I hope that there are more people who are vocal about this like you are. I think a lot of people cower under just the immense problem in front of them. I think it's intimidating, but together we will be able to chisel away at it and make things better for those who want it to be better.
it's a delight talking to you, Ari.
Likewise.
And thank you. Yeah, thank you so much for taking the time.
Thank you so much for spending some time with us today. We'll talk soon.